Of this because it's relatively new. Only in the last couple of years was it incepted and put together by the UEMS. It's a multidisciplinary joint committee whereby surgical skills centres could be networked, and it started as such. It was a surgical endeavour and it was born out of the division of general surgery. However, now it spans across many different divisions in the UEMS, and it is a fantastic potential opportunity for us to network our clinical skills centres, not only for surgery, but also for anaesthesia, for paediatrics, for cardiology, and the list is growing almost daily. NASCI was formed last year and has already accredited 6 centres across Europe, and we look to see that improving over time. And really that is one of the most exciting developments in networking clinical skills training across Europe in recent times. It is very important that we have such networks, because what we are seeing and what we have seen in the past is the way that we bring on new surgical technologies is perhaps not as scientific as we would like it to be. If I develop a new drug tomorrow, I will go through a very complex process with lots of checks and balances to make sure that I'm not introducing a new medication that is going to be harmful to my patients. Those processes are not in place for surgical technologies. I can start a new surgical technology on my patient cohort tomorrow, providing that the implements that I use have got CE marks or some form of quality assurance marks. Yet maybe they may not have the outcomes or the clinical data to support this. And we really learned a lot from the port site metastases story that we saw, particularly in the colorectal MIS history. You'll all remember the 90s when MIS was really taking off in more intermediate and complex procedures. And in surgical oncology, we were seeing these port site metastases, even in very early stage cancers, Dukes A, Dukes B cancers. We were seeing these potentially curable situations rendered incurable by wound site implantation in MIS strategies. And we looked long and hard as to why they were happening, and ours and other groups at the time looked specifically into the human pathological and technology interface. We looked at the operative environment, and we saw that we were modulating that operative environment by the minimally invasive strategy. Yes, we were getting good back-end improvements in that we were getting our patients out. We were getting our patients physiologically returned to normal quicker than perhaps with the open procedures, but we were modulating the environment that we operated in. We modulated what we were operating in. It wasn't room air, it was a hypoxic acidic gas, CO2. We were changing the temperature inside the abdomen. We were also changing the humidity levels and indeed the pressure. And all this had effect on the patient-tumor interface. And perhaps any spilled cells during those procedures were more invasive. They were more capable of implanting and growing. And certainly I and others showed that if you had a spilled tumor cell model, when you compared control and the ability for those cells to be invading across normal humidity, normal pressure, and normal gases, you were seeing a baseline level of invasion. But as you can see represented by the black circles, there was an increased amount if you used a helium pneumoperitoneum, and a significantly increased amount if you used a hypoxic acidic pneumoperitoneum such as carbon dioxide. And I think we all agree that the learning curve for MIS in colorectal cancer was certainly an issue in the port site implantation rate. We just don't see it anymore now with proper structured training models. However, we're just entering that with widespread acceptance of laparoscopic strategies for pancreas and for other surgical types, which may even be more difficult than colorectal. And we need to be really careful about how we bring these things to bear. So in that, with that care in mind, we also want to talk about the promise of technology. I, like most people in this room, quite like technology. It helps me in my day-to-day work. It certainly gets me on top of my emails from early in the morning to late at night. But in terms of pancreas MIS, we need to be especially careful. We not only have the difficulties and the technical challenges that we have of intermediate to high-grade MIS strategy, but also specifically related to pancreas. The visualization of the retroperitoneum laparoscopically is difficult. The reliance on haptic feedback for dissection is never more important than if we're taking out pancreas adenocarcinoma. And the complexity then, once we've taken it out of the reconstruction, is perhaps a significantly higher grade than what perhaps we're seeing in basic colorectal procedures. So although laparoscopic Whipple and laparoscopic distal pancreatectomy will now become more and more prevalent, we need to take care, and we need to take care in how we do these techniques over time. A lot of centers now for distal pancreas tumors are default laparoscopic. We haven't seen the explosion that we saw in wound implantation rates for these, but perhaps this is still a numerator and denominator issue, and it's something that we need to be careful of. Robotic and master-slave manipulator techniques are coming to the fore. They're not yet universally useful in terms of cost and in terms of reproducibility, but I'm sure with further generations, not just HD generations, but further generations of Da Vinci systems and other systems, we will be seeing them more and more used rather than less and less used. And they no doubt give us an extra layer of safety and an extra layer of complexity reduction in doing our difficult procedures, particularly in the retroperitoneum. We have a very good restoration of the visual quality, but also we have a very good restoration of the control, a control that is perhaps lost sometimes with laparoscopic surgery. The one deficit at the moment is haptic feedback, is the force feedback, where when we're actually feeling the tissues, we're not getting any feedback to the robotic operator. And when we are performing robotic surgery, that is one of the early learning curves that we go through, is to use the tissue deformation rather than the haptic feedback to work out that we may be perhaps tugging the tissues too strong. It has significant extra benefits, though, not only in terms of control of the vision, but also intuitive control of the 7 degrees of freedom that we have inside the abdomen. We have 2 little hands inside the abdomen, and this may be the single most important development to allow us to safely proceed on retroperitoneal surgery for more and more advanced conditions in the future. That advancement, though, needs to be coupled with a similar advancement with training methodology. Our old-style way of looking at a trainee and rendering them or deciding them competent based on logbook explanations and investigations is no longer relevant. We must ensure that they are competent. Gone are the days that we can say if they train for X amount of years, they are trained. We need to have measures, not just knowledge-based measures, which the UEMS and others are very good at, but also we need to have measures to define competence. And with these master-slave manipulators, with these advanced laparoscopic kits, we have a lot of data that can be derived from the actual procedures that trainees do. So what we need to move towards is a training to competence. We need to move towards a area where we can define someone as competent, perhaps earlier than the training scheme suggests, but also identify those trainees who require longer. Work in Imperial that I was involved with a long time ago now, which has progressed significantly, used very basic assessments. We were able to put hand trackers on trainees' hands and watch them do simple tasks, and very simply build a construct model, which is where we were able to see the novices, we were able to see the intermediates, and we were able to see the so-called experts and their range, and use then these trackers to define a trainee within this range. And that was certainly very useful, but unfortunately it reaches a plateau, it reaches a ceiling very quickly in what we can determine. So determining between an early stage resident versus a late stage resident might be easy for an intermediate task, but determining when a late stage resident is appropriate to transition into consultant practice is much more difficult using the basic models that we have today. Our group in Dublin have taken that a step further, and we're now using functional MRI, a technique by which we can put surgeons through our MRI machine and watch them think about doing operations. We also, in our early work, have showed that actually by doing simple tasks, we can develop the same construct we did with the ICSAD motion tracker 10 years before. But this allows us to allow someone to go in and think about how they would do various aspects of a pancreaticoduodenectomy, for example, and that allows us to work out where they are. So as an assessment tool, it's very useful to determine a nodal point, and this is going to become more and more important as globalization of medicine continues unabound, where we have doctors transitioning and moving between different healthcare districts on an almost daily basis. And the current method of assessing those doctors is to get a lot of paperwork from their home healthcare region and in some way, shape or form make an informed decision based on that paperwork. What I see in the future being significant and important is being able to discriminate these specific nodal points where a surgeon in Dubai can transition in perhaps a weekend to being a surgeon in Dublin and back again, and be able to determine that surgeon is of fit quality to enter in at a specific either training level or indeed consultant level, either in Dublin or Dubai. And that is going to form a significant amount of research over the next 10 years or so, because we have trouble defining competence as it is, but we have even more trouble defining what's the international nodal point on which these surgeons can change. So in summary, Mr. Chairman, ladies and gentlemen, in minimally invasive strategies, we have a defined and expanding role in HPB. Because of the complexity of the surgery, we're probably a little bit behind where other sites such as colorectal surgery are. But we need to learn those lessons from the colorectal surgeons in how we bring forward our MIS strategies in pancreas surgery in particular. And with that, hand in hand, we need to make sure that our training methodology is fit for purpose. Thank you.
Any question from the floor or any comment, please?
That NASCA widens its perspective to include clinical training centers, because there is no body that is really doing this.
Okay. So, first, please, thank you for that. So the question was, for those just who didn't hear it, was should NASCA, which is the network of accredited skill centers in Europe, which is a fledgling organization, should they accredit the clinical training? And I think it being a fledgling organization, that is perhaps not within the remit just at the moment. The clinical skills centres that we are accrediting and are going on to accredit are accrediting the buildings and the people within the buildings, but has no desire at this point in time to credit content. I think a large organisation such as the UEMS has other things in progress around that. Professor Papalos.
If I may comment in answer to Professor Felice's question, the UEMS is doing that since 1997. There is a very robust program for appraising training centers across all specialties. And this includes a very formal application and comprehensive application, following by an on-site visit and scoring in more than 25 domains. And the currency is always activity, clinical and academic activity per trainee. And then a center is accredited or not. And at the last Management Council meeting of the UEMS, I introduced some updated guidelines about this, which are going to be approved in the next council meeting in April. And across the board, there are specialists, for example, like ophthalmology or gynecology, doing this for 15 years, and they accredit more than 20 centers a year. And other sections now and other specialties are picking up as well. So it's a very well-developed project across the UEMS for many, many years now.
Thank you very much. Professor Ridgway. Next speaker will.
We're glad now to call Professor Antoni Szczepanik from Poland. He's a professor of oncology and gastrointestinal surgery from Jagiellonian University in Poland. Welcome, Professor.
Good morning. First, I would like to thank the organizers to invite me for this excellent meeting. And I hope that my presentation, being not about the pancreas and the training, will also be interested for you. So we are facing, all of us, in the increasing number of elderly patients with different diseases, and also the problem of treating the liver tumors in elderly patients. In the 70s and 80s of last century, the operative mortality for patients undergoing hepatic resection, major hepatic resection, was reported as about 1% for younger patients and more than 10% for patients older than 65 years. In the same period, the operative mortality for older cirrhotic patients was reported even higher, as 30%. And in more recent studies, what we can read now is the oldest age is a prognostic factor of in-hospital mortality after liver resection. And mortality after this resection in elderly patients has the complication rate of about 6 to 8%. And a recent American study of ORCAD, which was based on almost 1,500 patients, where elderly patients, found the mortality lower, about 3.3%. And we shall remember and consider that our elderly patients have a shorter life expectancy as a result of mainly of comorbidities and the advanced age. And for them, quality of life and recovery is more important. Coming back to the American study of ORCAD, age over 75 was associated with the increased need of transitional care after hospital. And however, also it was associated with the comorbidity index, so we are really not sure if it was the age only or the comorbidities too. And overall low postoperative mortality rate observed in these patients supports the use of liver resection, active treatment of liver tumors in this patient, but when they are appropriately selected. So let's look at the primary hepatic carcinoma Japanese experience. Before 1990, the median age of primary hepatic cancer patients was about 60 years, and 20 years later, in 2010, it was reported as 71. And tumors were more advanced in the youngest group, but of course, the survival was worst in the oldest group. However, we shall consider that elderly patients survive for the highest percentage of their life expectancy after receiving an active treatment for hepatic malignancy, primary hepatic malignancy. So authors conclude that the age should not be a contraindication for active treatment of primary liver neoplasm. Let's look at the clinical practice for more common disease like secondary liver neoplasm. In the studies reporting natural history of colorectal liver metastasis revealed that even half of all patients presenting with liver mets were older than 70. However, in studies about the treatment of colorectal liver metastasis, only up to 20% of patients were older than 70 years. So this difference may reflect a process of selection of patients favoring for older patients palliative treatment or even supportive care. Another option for the treatment of liver tumors is radiofrequency ablation. And when we look at some data, there was no difference between hepatic resection and radiofrequency ablation in patients with small primary liver cancer, which was smaller than 3 centimeters. So results were equal. And, but the other reported that in the general community, patients treated with radiofrequency ablation have a similar risk of adverse event to those treated with hepatic resection. But it was general community. The difference is in specialistic centers which are familiar with the technique of radiofrequency ablation. And in those centers, the number of complications, the risk of complication is lower for radiofrequency ablation than for hepatic resection. What are the guidelines for radiofrequency ablation of a liver metastasis, liver tumors by National Institute of Health? So it may be indicated as a primary treatment for patients who are unfit for surgery in the treatment, primary treatment or the recurrence post-resection. It also may be used as an adjunct to hepatic resection to treat a small fucus, a small lesion in a remnant liver. So I would like to present a series of patients from our department in Krakow treated for liver focal lesions. There were 813 patients treated between 2005 to 2014, and the median age was 62. Looking at the structure of the age, 43% were older than 65 years, and the rest, 57%, were the younger group. Looking at the structure of the groups, we can see that there were 100 patients who were older than 75, and 253 patients who were between 65 and 74. What was the diagnosis? This were not only malignant tumors, but in an older group over 65, the primary liver neoplasm was 90 patients, secondary, so metastasis, 239, benign tumor 17, and other 7. So this group consisted of 353 patients. And the younger group, it was 61 primary liver neoplasm malignancies, secondary was 309, benign 56, and other 34. So this group was bigger, 460. So looking at the distribution of the diagnosis, we can see that in an older group, it was an increased percentage of primary liver tumor and similar percentage of liver metastasis, but the percentage of benign lesion was lower. So what were the procedures for those patients? For the older group, resection of 1 to 2 segments was performed in 41 patients, resection of more than 2 segments, so 31, and non-anatomical resection 50, and radiofrequency ablation in 215 other procedures like drainage in 16 patients. In the younger group, the procedures were similar. However, we can see that the group was bigger and the number of radiofrequency ablations was smaller, so rather more aggressive strategy. And the distribution of procedure is that we'll clearly see that more radiofrequency ablations in the older group, and other procedures were similar, but there was, except radiofrequency ablation, the difference was not significant between. But the main thing is, what was the outcome in these patients? But because, of course, we can do anything, but the interesting thing is the outcome. We'll look at the safety of a procedure. So the length of hospital stay in resection cases was slightly longer in patients in the older group. It was 12.3 days compared to 10.4 in younger groups. And 30-day postoperative mortality was about 1.5% in younger, 1.7% in the older group, and the major surgical complications were 6.6 in the younger, and the lower rate 4.1 in the older group. But there were no statistically significant differences. And the similar results are in radiofrequency ablation. So there was no difference in length of hospital stay and 30-day postoperative mortality and the major surgical complication between those two groups. In conclusion, I'd like to say that in the older group of patients, there was an increased incidence of primary liver neoplasm, which is in line, for example, with the Japanese experience. And radiofrequency ablation was more frequently used in older patients. And resection and radiofrequency ablation had similar outcomes in both groups. And the perioperative risk is acceptable in older patients. But these results are the effects, of course, of patients' selection and the treatment adjustment to the age and comorbidity. Thank you very much.
Thank you, Professor Anthony. Any of the audience have any comments or any question? Yes, please.
Hello. Thank you, Dr. Anthony. I just wanted to ask about any significance of TACE adding with RFA, like transarterial chemoembolization before going for this robotic knife or radiofrequency for the tumors.
I couldn't understand it very well.
It's an intraarterial chemo. It's an intraarterial chemoembolization for the tumors, liver tumors, HCC, before going for this RFA. The downgrading of the tumor size.
So you think the criteria for radiofrequency ablation?
No. I just want to add.
We rarely use the chemoembolization in our center. So there were a few patients who were chemoembolized, and that's why I didn't analyze it.
Because we have in India with some centers, with some series in which we are going and giving the chemoembolization. Rather, we are embolizing the portal vein, the part of the portal vein also. And after that, the downgrading of the tumor or the tumor size, because once the chemoembolized tumor, if you go for again the MRI findings, it becomes a solid organ, solid lesion. And then when we give the radiofrequency, the effects are very good.
So, of course, as I said, we can chemoembolize rarely. So, of course, it's a valuable method to do it.
Thank you, sir.
Thank you.
Tony, thanks very much. Really enjoyed that talk. Can I ask a question? How old is too old? Frequently now I'm asked to see patients who aren't fit for FOLFOX or FOLFIRI, but I'm asked to consider them aged 83 for an isolated MET or low volume disease or something that we can address laparoscopically. How old would you go, and do you do any preoperative screening on these patients that is specific to your unit?
That's always a question. Who is too old? And the oldest patient in this series of patients was 84. And but the metrical age is not an indicator. So in patients who are over 70, we are, of course, trying to do all necessary consult and also a battery of tests which are specially prepared for elderly patients. And if this, the performance status of a patient is good, so we can't say it's too old. Sometimes we can say it's more the status and the comorbidities that limited us than the age. Of course, we also look at the life expectancy, but 80, 82, 85 isn't too old for example, radiofrequency ablation if the general condition is good and the life expectancy is longer than a year.
Thank you, Professor Anthony.
The next speaker will be Professor Vasilios Papalos. He is the consultant transplant and general surgeon, Imperial College in Hammersmith Hospital, London, England. His presentation will be pre-transplant kidney and pancreas graft preconditioning. Please, Professor.
Thank you very much, Mr. Chairman. As you have noticed, I reversed my talks, and I will present the clinical one first, followed by the research one, so that the whole thing will make a little bit more sense. Again, many thanks for your most kind and gracious invitation to give these two lectures in front of this prestigious audience, and I can see in the audience a very nice mixture between experience and youth. And I sincerely hope that after my talks, some of the members of the youth will be attracted to the field of transplantation surgery, where we so desperately need them. My first presentation will be an overall view of our kidney and pancreas transplant program at the Hammersmith Hospital at Imperial College in London, focusing predominantly on the high-risk kidney and pancreas transplant program. A few words about our own program. The Renal and Transplant Unit of the Imperial College Healthcare NHS Trust is a big trust, the biggest trust in the United Kingdom, and it consists of 5 hospitals, which is Hammersmith, St Mary's, Charing Cross, Queen Charlotte, and Western Eye. The annual budget of the whole trust is £1 billion. We have 10,000 staff, and we are looking after approximately 1.2 million patients per year. The Imperial College Healthcare NHS Trust is also a very strong academic institution, with Imperial College being the academic engine of it. We are an accredited twice academic health science centre and biomedical research centre, and we have at our disposal more than £100 million over a period of 5 years for research, predominantly translational research. The Renal and Transplant Unit, in which I have the honor for almost 20 years now to serve, is the product of the amalgamation of 3 transplant units, that of St Mary's, where I grew up, Hammersmith and the Charing Cross, in one unit at the Hammersmith site, an amalgamation that took place in November of 2005. Its structure is the hub and satellites model. So we have a hub, a big hub at the Hammersmith Hospital, and a huge amount of satellite units across northwest London, which is our own units run by us and feeding into our own program. And we have a truly integrated multidisciplinary team. So any one of you who is aspiring to be a transplant surgeon has to understand that he has to work extremely closely with nephrologists, with radiologists, with pathologists, with psychologists, dietitians, and the list goes goes on and on and on and on to have a successful outcome. In transplantation, usually the surgeon gets the glory and the kudos, but the work is always being done by a very committed team of people. And you can see here the way it is. We are looking after approximately 1/3 of the greatest London area with our hub and satellite system, a catchment population